Okay, welcome everyone. For those who joined us right on time, we love a prompt visitor. Yay. This is the second episode in the series Comprehensive Family Care, led by our incredible licensed midwife or certified professional midwife. Am I correct?
Mm-hmm.
Getting to know your licensures really well. This is super exciting because, as you remember from the first episode, about a month and a half ago, we really targeted the intended parents, whereas this one's going to target more the surrogates. And then Heather's going to do a great job of rotating back and forth to really show that midwifery is accessible to all. You don't have to be the surrogate. You don't have to be the intended parent. You don't even have to choose a midwife in your birth. All of it is an option, and just the knowledge that she brings is going to be wonderful. So today's topic is preparing for delivery and beyond. And Heather, even though we've introduced you many times, I'd love you to just take a minute and introduce yourself and tell us a little bit about your professional background.
Yeah, absolutely. So my name is Heather Smith. I am a certified professional midwife and also a licensed midwife. We'll kind of get more into that a little bit later. But I began my journey as a midwifery student in the very beginning of 2019. I got a little bit of time in before the pandemic hit and things got really crazy. I've attended over 1,000 prenatal and postpartum visits and almost 100 births. And I became a licensed midwife in May of this year. So I'm a baby midwife. I absolutely love helping families grow, and I feel like that is what is so beautiful about being able to work in case management for family source consultants and as a midwife. They come together beautifully. I'm also, outside of midwifery and family source, a mom and a partner and all those things. So
love it. Welcome. I've met you a million times, but I can never get used to you. I want to hear you introduce yourself every single time. So you kind of touched on a little bit, but what is a midwife, and are there different certifications for midwives? Basically, what makes them different from OBs? Kind of just the whole question all wrapped into one. And while you're answering that, I'm going to type this question into the comment section just so I can put it up on the screen for the audience.
Yeah, absolutely. So this is a very, very detailed question because there are different types of midwives in every state. So, OBs, obstetric providers, they are doctors who specialize in obstetrics and gynecologies. And a lot of people also don't realize they are surgeons. So they do surgery. And midwives. So originally, midwife comes from the Latin word that means with women. And so at its core, a lot of people will tell you that midwifery is the oldest profession. There's a little bit of debate between midwife and another profession. But midwifery is one of the oldest professions because women have always needed support while they're having a baby. So midwives, there are two main types that you will hear about. There are certified nurse midwives, and these are nurses who have gotten a much higher level of certification and specialized in midwifery. They are more often found practicing in hospital settings with an OB. Occasionally, you will find a CNM who also works in a home birth or birth center setting. And then you have certified professional midwives, which in over 33 states and DC, they are also licensed by the Board of Midwifery. But depending on your state, certified professional midwives may not be licensed, which would make them illegal. So it is important to look into your state's laws. But for certified professional midwives, I went through about 4 years of school and apprenticeship. You can go to a college that is what is called MEEC approved. Or you can do just an apprenticeship route that fulfills all of the requirements from the North American Registry of Midwives, sit for your boards, and then become licensed through the Board of Medicine in my state, which is Virginia. So if it's something that you're interested in, I would definitely look into the state that you live in.
Okay. So again, for the audience here, Heather's going to be available for all of your questions live. Obviously, if you have any, you can post them at any time. We are live on Facebook, we are live on YouTube, and we are live on Twitter. So go ahead and submit your questions. However, since we advertised this well in advance, we received a lot of questions in advance. So these are the questions I'm currently asking Heather to get all of the pre-submitted ones out of the way. But if you pop in with one, I you. She's going to answer it. We do not have to worry about you not getting your own time. So the next pre-submitted question, Heather, is why would someone choose a midwife instead of an OB? And when would an OB be a better fit for a woman?
Yeah, this is a really great question. So, a lot of women choose midwifery for their pregnancy and childbirth when they have a desire to have the most intervention-free birth possible. Midwives really take like a natural approach. So, we focus on, health, nutrition, wellness, and preventing problems with those things. And so, OBs can, they can be absolutely wonderful, especially when there are existing things that would make you high risk, or treating, like if you already had a preeclampsia, gestational diabetes, then it would probably be a better idea for you to have an obstetrician. And we can go more into that later. But most people just are looking for a different experience. That's often what we hear: more personalized, more, intimate care. We spend about an hour in every single one of our prenatal and postpartum visits with our clients. So it's definitely like a lot more one-on-one time. And so that is why a lot of people come to us for care, and just midwives in general, just the desire to keep birth a normal life event instead of a managed medical event. And sometimes birth is a managed medical event. So it's really important to keep that open mind of, birth is a natural process, but often we do need doctors and hospitals.
Okay. So this is not one of the pre-submitted questions, but I just thought of it. At what point, and maybe it is a question already, but at what point, let's say I choose to have a midwife during my birth, and now at some point I think a doctor needs to be involved. Do you as the midwife say, look, I think this is outside of my scope now, let's get involved? Do you prepare that in the birth plan for the woman to help them? It's traumatic in general if you have to switch your birth plan. So what steps does someone take, and how do we know, okay, now the plan isn't going to work?
Right, absolutely. So when you come into care with a midwife or with an OB, they should always do an assessment of your past medical history. And so in order to be a midwifery, like a candidate for care with midwife, you do have to be fairly low risk. And that's what makes it safer to make these choices if you are desiring a birth out of the hospital space. And so during pregnancy, we do the same labs, ultrasounds, the same schedule of prenatal visits. And so if something develops during pregnancy, it is a constant conversation of informed consent, letting you know, okay, right now this has developed, these are the risks, these are the benefits. And it's always an option to transfer care to an OB. Now, there will come a time, or there can come a time, where we just kind of have to draw a line in the sand and say, this is outside of our scope. This situation really needs to be managed by an OB in a hospital setting, and we will make that recommendation at that time. For us, I can't speak for every midwife. We try really hard to make that transition as smooth as possible and accompany them. So we would offer to accompany them to their hospital birth in a support, as a support instead of as their medical provider in that setting. So, transports absolutely happen. And that's something that I think is really important to know. We have more and more surrogates who are asking about birthing with a midwife out of the hospital or in the hospital. And we can get into that too. But it is really important to know that your risk as a client is constantly being assessed throughout your pregnancy.
Okay. So we'll probably address this later, but here I'm ready. It's birth time. We're here and everything's happening. And now it comes to the point where it's possible that we need to transport over to the hospital. Is this an ambulance ride? Is this a panic moment? Obviously, I've seen it. We all say this, right? I've seen it on TV. I saw it on a TV show in a reality series where a woman was having a midwifery birth at home, and the cord was wrapped around the baby's neck or something, and they couldn't quite, make it work. And so they had EMT show up and didn't have time to get to the hospital. But who makes that call? What if the mother is not able at that moment to give consent? How do you handle that? And these are really now my questions. I forgot to go on script, so we'll just ask this and then I'll get back on track.
So the cornerstone of midwifery care. So, and one of the things I was going to get into is the biggest difference between like the obstetric model of care and the midwifery model of care is that we are not in charge, we are equals. And so we give you all of the information. And so in labor, until a certain point, if what we kind of specialize in is we have skilled hands, but we know how to sit on them until they are needed. And so we try to keep things really low intervention, and we do a lot of monitoring. If we were to recognize a problem that it wasn't emergent, but it was something that we were not comfortable with, we would recommend transferring to the hospital. Depending on what that was, if they declined, they may be able to sign a form and continue. If it was something that we were absolutely not okay with continuing in an out of hospital setting, then EMS would be called.
Okay.
If it were a truly emergent situation, then we would call EMS to come. Often it is something as simple as picking up a difference in baby's heartbeat during labor and saying, I don't really like that, or a change in mom's temperature or her heart rate that makes us think maybe there's an infection developing. And so often those are not emergent transfers. And frequently we go to the hospital and everything is fine. But I always say I would rather go to the hospital and everything be absolutely fine than stay home and wish that we had gone to the hospital. And I feel like that is how most or all midwives should practice.
I love that. And I know we kind of jumped way ahead of the schedule in questions, but I wanted to bring it up because we do have a lot of surrogates who are applying to be a part of us, and they would like to have a home birth. But, there's myths that go about it. There's lots of different things. So we'll have a whole other episode one day on the myths surrounding, midwifery. But because of that, there's once you choose, you're in it, and there's no way out, and there's always a way out, and it's not a way out. It's transitioning.
There's always another option. Yeah.
Exactly.
And there is the option
of the baby.
There's always the option too of like, if something comes up prenatally that is outside of our scope, we have OBs that we work with, that we consult with, that we can send mamas to get that OB's opinion. And, if they say this is fine, absolutely. Like, I think they're still good to go. Great. But if they say, no, I think that they need to be managed in a hospital setting, we could do co-care, which is like where you see the OB and you see your midwife. And then if you birth in the hospital setting, again, the type of midwife that I am, we would come to the hospital just as a support, not as a medical person. But then that also leads into the conversation of certified nurse midwives. So many hospitals now they will have a practice of certified nurse midwives that work with OBs in the hospital setting. And so interestingly enough, America is one of the only countries, modernized countries, that still uses does use an obstetric model of care. The UK, Australia, Canada all use a midwifery model of care. So there, if you are having a baby and you are not high risk, you are using a midwife. A lot of the time in the hospital setting, but you have a midwife that does all of your care. And then you only have an OB if you are high risk. And so America does things a little bit differently, but you can find similar care to that in most hospitals today with a nurse midwife who would be, it's just a little bit more like personal care and, more aligned with the physiologic birth approach, but then you're still in that setting if something, because birth doesn't always go to plan. So you have that kind of safety net there.
I love that. I love that it's a partnership. It's not an either or. So with that, we'll get back to the predetermined questions now, the pre-submitted ones. Can a surrogate use a midwife instead of an OB? And whose choice is it?
So a surrogate can use a midwife instead of an OB. And we do absolutely have plenty of surrogates who use a midwife, whether that be a nurse midwife in a hospital setting that's in practice with OBs. And we've also had surrogates that have planned births with CPMs and birthed out of the hospital, whether that be in a freestanding birth center or home birth. But it should always be something that is discussed up front when you're in that matching process with your intended parents, because this is their baby. And so this should be something that everybody is in agreement on. And Anne has a really good understanding, because we have a lot of international parents that we work with. And so if they are from those countries, they may find it odd if you're not using a midwife. So to them, it might need a little bit more conversation of, well, here, midwives are often community health workers, and I'm planning a birth at XYZ. So, a lot of our case managers have previous surrogacy experience, and I am one of the only ones that do not, but I am planning a surrogacy journey, and I will absolutely be opting to use the midwifery team that I work with and birth in our birth center. If I was having another child of my own, I would choose a home birth. But when I look at the level of risk, because there are different risks associated with pregnancies that are a result from IVF. And I think that's something that's also really important to look into, do your homework on. I would still choose to birth in the out of hospital setting, but at our birth center, which is about a mile away from the hospital. So there are always different options. And I really encourage people, if they are looking for other options, to go ahead and look and know what you want when you go into that match meeting, so that you can have this discussion. I think that it's a good idea to be open-minded, because again, like, this is their baby. And so when you have that conversation, try to, be considerate of their perspective, but birth is happening to your body. And so you should absolutely have a say in your provider and where you're giving birth.
And there are plenty of intended parents who support this model versus the other. So don't change what birth plan you would like just based on that. Know that we'll find intended parents for you. So you slightly answered this already, because again, I jumped the gun earlier, but can midwives deliver babies in hospitals? And I think there are some that can, some that can't. But if you let's say you're my midwife, can you help me, or do we have to partner with a nurse midwife?
Yeah, so you would have to either have a nurse midwife or an OB in my state and in most states to birth in the hospital. So you could choose a birth center birth, which is a really nice middle ground. But if you wanted or needed a hospital birth, you would need either a certified nurse midwife or an OB. And I think that, it's also really nice, because maybe you wanted to birth out of the hospital with a CPM, but something came up in your pregnancy and now you need to birth in the hospital. There's still that, okay, well, I could probably be a candidate for care with the nurse midwives and birth in the hospital. And so I always encourage people, even if, this is what you wanted and this is how you pictured your birth, even if your risk status kind of changes during pregnancy, you can still have a beautiful birth no matter what.
I love that. That was a perfect little ending to the answer. So the next question, if a surrogate chooses to use a midwife, can she also offer pain medication or an epidural? This one is very important to me, because I'd like to know.
So if you are birthing in the hospital setting, yes. The nurse midwives that are near me, where I live in Virginia, they offer IV pain medication, epidurals. Also, they recently got nitrous oxide, which is gas, laughing gas, which is what is used in the UK and Australia, and can be a really nice alternative. If you are birthing at home or with us at our birth center or with any CPM, there aren't any pain medications or epidurals. We use a lot of alternative pain management. So birthing or laboring or birthing in the water is a really good tool for pain management. We do a lot of education during pregnancy on things that you can do. Lots of hands-on support. We call them hip squeezes and pressure on your back and massage. And those are the things that we can offer out of the hospital. I don't think this is a question on here, but a very important question if you are considering utilizing a CPM out of the hospital every state has different laws surrounding medications. So in my state, for instance, as of July, it is now legal for us to carry and administer emergency medication. And that varies from state to state. And I would, especially in with a surrogate pregnancy, I think that's a very important question to ask if you're considering a midwife. Are you able to carry and administer medication? So if there were to be an emergency, do you have the option of using those medications to resolve that emergency? Because not every state has allowed that, even if they license midwives.
I think it would be super helpful. I'm going to give you a little action here, Heather, to help me with Crystal come up with a state-by-state list of some of the laws, link to the actual resource that we're pulling it from. So on our Becoming a Surrogate page, we can have a section that says hospital birth, midwifery birth, and we can give them a little bit more information because we talk about it on here. I'm not a video watcher, I'm a reader. So if I see it on the website, but we will, audience will take that action and get kind of a library, if you will, for some of this. And it's not anything that we're going to write on our own. We're going to pull it directly from the resources from those states, but we'll get that information to you. So I love that. So our next question is, and I typed it up all fancy. So it says, let's talk delivery. When coming up with a birth plan, what are some factors that a surrogate should consider that might have been different from her own deliveries?
Yeah, I really love this question because there are so many different factors to consider when you are a surrogate, because you are carrying and birthing the baby, but ultimately it is the intended parent's baby. And so there's a lot of different thoughts and opinions. And so I think the big thing when you are creating a birth plan as a surrogate is communication. So having close communication with your intended parents is absolutely crucial. And then there are so many things that go into that. So at Family Source, we actually send out a birth plan, but it's not the typical birth plan that you would think of. It's more about like who's filling out the paperwork, who is getting a hospital ban. So these are really important questions that should be asked. I think recently it was something that we worked out between a surrogate and intended parent of who's cutting the cord. If you desire or the parents desire delayed cord clamping, having that conversation up front, because that's like a new big thing, even in hospitals. And many hospitals are just doing it. They do it at every birth. Even C-sections get delayed cord clamping now in many hospitals. Talking about like immediate skin to skin contact. Do the intended parents want that? And as a surrogate, encouraging that because that is so important for them. Also, like, are there cultural or religious practices that either the surrogate or the intended parents would like to be observed? That is extremely important. So I think that having those conversations early in the pregnancy and often can be really helpful.
Is there something that we can include? I know it's not a checklist, if you will, but is there something that we can include on our website that has kind of like an example of a birth plan of those questions that we can provide to our surrogates and intended parents for them to take a look at it and really, because maybe they don't know what to think of and they don't know until you're in the situation. But if we could give them a draft, maybe that would be super helpful. And I'm sure you've already created that, but I'll just commit to getting it from you at some point and getting it on our website for others to see, because I think that is so important. I didn't even think of the delayed cord clamping until you brought that up, but I love that that's an option and they can do it. And then whoever is on the birth plan to be the one who cuts the cord, they can follow through with that. So that's a beautiful way to make surrogacy more intimate for all parties, and not just because you're not carrying the baby. I may or may not be able to carry my own, and that will be important to me. And I absolutely love that. I'm a little choked up now. I love that as an option. So
one of the reasons that, I really want to put this out there. There is nothing wrong with, I've had babies in the hospital. I've had babies outside of the hospital. If depending on my situation, I would absolutely birth in the hospital if it was needed. Many women want to birth in the hospital because they're like, I definitely want an epidural. The thing about where you are birthing and how you are birthing is that it doesn't matter like what your choices are as long as you feel supported in them. And so it's really important that if you know I had a cesarean with my last baby, I really just want another cesarean, that is absolutely fine. It's important to have that conversation. Like that should be something that's discussed in matching. Same as if you're like, I really want to have a home birth. That should always be something that's discussed early. And then you will have a team of people around you who support you in your decisions. So I think that it's really important to discuss these things early. And then, like I said, very often. And I have really often thought about, all the things that we could offer, like a birth class for intended parents of like, this is what is going to go down in the delivery room. And because so often when I speak with my intended parents, they're like, it was so different than what I thought it was going to be. And one of my very favorite things about midwifery care is if that is something you are considering doing, the intended parents, if they make it to the birth, can be so involved. So we frequently have the last baby that I had an 8-year-old sister helping me catch that baby. And so it's really nice because it is family-centered care and the intended parents can be so involved. I've seen a lot of surrogate, like home birth stories where the intended parents got to be like so hands-on, and it can be a really, really nice way to build that bond and communication. It is absolutely not going to be for everyone, and that is okay. The main thing is that everybody feels supported and heard during this really, really important time.
I think that is a message I keep hearing. It's being slightly terrified of a home birth because of pain levels. The concept of having an entire care team in my best interest, not necessarily there for a surgery or a major medical concern, but there to support me in every step of the way, is kind of enticing. And I can see why so many are interested. And I also love the thought of having intended parents be more involved because of the setting. That's a beautiful option. Not that it's right for everybody, but it is a beautiful option. So I know you touched on this a little bit, Heather, but I'm going to ask the question directly. So physically, what are the options for where the baby is placed or held right after delivery? And I think you kind of mentioned the delayed cord clamping, but let's talk about this specific piece.
So typically, and I think this would be the same whether you birth in the hospital or at home, baby kind of immediately goes up on the birthing person's chest, and that is due to location. Baby has a cord that is normally about 18 inches long, similar to the length of the baby. So they can't go very far while they're attached. And I'm always reminding people of this because I'll have like fathers who are like, I want to hold the baby. I'm like, they're still attached. Please do not take them because they will forget. And so that is something to consider when you are talking about delayed cord clamping. So the idea used to be as soon as the baby came out, they would cut the cord, and then baby could go to the warmer, or baby could go immediately skin to skin with the intended parents, which does have, that is very, very important. And then the idea of delayed cord clamping started coming up, and that about a third of the baby's blood volume is left behind in the placenta if you do not wait and do that delayed cord clamping. Now, there are many schools of thought about what time frame delayed cord clamping actually is. You will get very different answers if you ask a doctor or you ask a midwife, but in the hospital, it's generally 1 to 2 minutes. And so that is a very small amount of time. And typically what's happening in that 1 to 2 minutes is the first steps of what we do when a baby is born. So drying and stimulating the baby. They might put some warm towels on baby and rub their back, and they do that to like get baby going and elicit some good responses and crying from them. And normally that 1 to 2 minutes will pass really quickly. And so then once that cord has been cut, that baby should go right to their intended parents. It's really important. The last webinar I did, we talked a lot about brain development and all of the hormones that are released. And so putting that baby chest to chest with you with, if you can have like a button-up shirt and getting them right in there. Some hospitals, and they all should be willing to do this, to like give the parents a gown if they want it, so that baby can just get tucked right in there. And that elicits your body to put out oxytocin, which is like the love hormone, the bonding hormone. And it's really important to this whole process. So if you are able and willing to get skin to skin with that baby right away, that would be wonderful.
And this is all pre-arranged, pre-discussed. So the hospital's on board. Everyone knows exactly how this rhythm is going to flow. And there's no, oh, what was the step, right? It all works seamlessly most of the time because there's a plan in place, correct?
Yes, absolutely. And it's important to note that if there were any complications or emergencies, these things can always go differently. So if baby needs a little extra help, they will likely, cut the cord and take them over to the warmer and do all those things. And that is just something that can't be avoided, unfortunately. So I always remind people that like we can make all the plans when it comes to birth, but really everything is up to the baby and how the birth goes.
Yeah. I'm learning that very much so. I've had some friends who had a strict birth plan and ended up in a C-section, and then they're like, wait a minute, I was supposed to be, at home. And so I'm fully aware of that. And I love that you added that. So I kind of have a question. I'm going to go back a little bit. We talked about midwives, we talked about OBs, but what is a doula? And if a surrogate has a midwife, should they also consider getting a doula? Is it another part of the care team, or are they competitive roles, if you will? What is it? Help me, because I don't even.
This is something that has been coming up a lot with our surrogates, and they're actually adding it into the contract to have their intended parents pay for a doula. So a doula is very different from a midwife. So a midwife is a trained, well, for us, we're licensed medical professionals. But a doula is not a medical professional. They do not give medical advice. They do not make, or they should not be making medical recommendations. They are solely somebody who provides advocacy and support during pregnancy and childbirth and the postpartum period. So essentially, if you were planning a hospital birth, but you wanted to avoid an epidural, I would highly suggest having a doula there, because they will come in and give you all those hip squeezes and all that massage and help you change your position frequently, which can encourage baby to come down. And so basically doulas are trained support people, and they are there 100% just to give you support throughout pregnancy and labor and postpartum. And I think that every mama, like personally, every mama should have a doula, whether they are birthing at home, in the hospital, at a birth center. Doulas are absolutely amazing and invaluable.
So kind of walk me through, these are the last of the pre-submitted questions. So for those of you watching or who have watched or popped in, if you have questions that were not answered by Heather, feel free to comment on any of our posts about this webinar, and we'll get them over to her, and she'll do a video and record it, and we'll get it out to you. But kind of to go through that last question a little bit, Heather, can you walk me through an example of, I've chosen a midwife for my birth plan, but I also have a doula. What is happening with each individual during the moments of birth? Who's where, who's what is intended parent do? What is the surrogate's partner do? What does the doula do? What is that happening kind of in this room? Kind of walk me through what that organized chaos looks like, if you will.
So typically if the surrogate has a partner, which they don't always, we do absolutely welcome single people as surrogates. So if they have a partner, they are often they're completely focused on the surrogate, and the doula is like a second person. So in the moments of giving birth, you would have a doula who maybe is applying a compress to mom's head, giving her sips of her water, encouraging her, helping her with her breathing. And then, of course, you have the midwifery team who is gloved up, catching a baby, supporting the birthing person's bottom to help prevent tears, monitoring their heart rate, their vitals, charting. Those are the things the midwifery team is doing. And then if you have intended parents, they can be as involved in that as they want. So they can be right there in the action, or they can be, standing back a little bit. They can be offering additional support to the birthing person. It is completely up to whatever everybody is comfortable with. And in the hospital setting, a doula would be, the same thing, right there with the birthing person, offering support, giving them sips of water, encouraging them, hey, let's try to push in this position because we've been in this one for a long time. And so that is kind of their role versus the actual medical team role.
I love that. And so this is a question because I'm really uncertain, but you know, I'm giving birth. I'm in the hospital now. We've had to transition there, or maybe I want my midwife there and I still want a hospital birth, but I want a midwife just to be there. I've got my doula, and you know, how does that situation look like? Am I allowed to have you both in the room along with if I had a partner and the intended parents? Is there a limit? Is it hospital based? Depending, kind of, how does that work? And I'm sure we'll cover this in another webinar, but now I just thought of it.
So it is very like hospital dependent. You know, when COVID started, there were very strict restrictions. And I know that that was felt throughout the you know, gestational carrier world. Like everybody felt that, of like one person. Sometimes people were birthing completely alone. But those restrictions, at least where I am, and I know most places have lessened. And here, there's not really a limit. Although I would say, you know, we kind of joke and say that each additional person in the room adds like an extra hour of labor, because labor is a very intimate process. And so
Okay.
part of being a surrogate is knowing that I'm going to invite these people who I don't know very well yet. Hopefully you will get to know them over the course of your pregnancy. And you are knowing that you're going to invite these people into your space during such an intimate time. And so that's why I encourage like such close communication. But most hospitals, especially in a surrogate situation, they are more open-minded. My local hospitals do not have a limit. They're like, you can't have like a whole basketball team in here. But they are very like open-minded. And I've definitely been in some pretty like we've done, you know, we've transferred from home to the hospital and kept like almost all of our birth team has gone with them to support them. And then they've had family there. So it's been like a crowded situation. And we try to make ourselves pretty small and unseen so that we're not bothering and taking away from what would be the birthing person and the intended parents moment.
I love that. Thank you for answering that. One final question, Heather, to kind of wrap it up. What advice would you give to anyone looking to become a surrogate?
Yeah, I think I love this question because you'll get different answers from every person that you ask. And like I said, I have not done a surrogacy journey yet. I work with surrogates and I am planning a journey. And the things that I think are really important is, you know, first of all, communicate openly from day one. Like really be okay with, you know, just putting out your expectations, your boundaries, and all of those things. It's very important to work through those early and consistently. And really, if you're planning to become a surrogate, prioritizing your health and wellness from like the moment you start thinking about that, because the healthier you are, if you are considering a different, you know, like maybe I don't want to birth in the hospital, that will increase your chances of being a candidate for midwifery care. But also, no matter where you birth, it will give you better odds of having like a really healthy pregnancy and a healthy outcome. So, you know, putting your physical and your mental health at the forefront. You know, I would also say do a lot of preparation, prepare for the emotional aspects of surrogacy. There are many, and I know that at some point we will talk about that, but the emotional impact, not only for you, but for your family and the people that you care about. And ask yourself, like, do I have a support system that is going to be able to support me post-delivery once this baby is with their parents? Do I have people who will gather around me and support me? And if not, then start looking for that. You know, attend some mommy groups, find a, you know, if you're religious, find a church home. If you aren't, find like a crafting group, you know, find your people, because you're going to need support. And Family Source does a really amazing job. And so my final thing that I'm going to say is get an amazing agency, because Family Source consultants provide so much support to their surrogates. We have a person who is just there as a surrogate support manager, and she is wonderful and amazing. And she gives so much support and just checks in with our surrogates all the time. And then you have a case manager who is right there walking through this with you every single day. And I cannot just express like the importance of having a great agency and, you know, not doing this on your own. So, you know, and then just be open-minded, embrace the journey. Every journey is going to be so different. And, you know, you can have expectations, but keep an open mind.
I love that. Thank you again, Heather. It's always a pleasure when I get time to spend with you. I'm thrilled for the knowledge that you bring to potential surrogates, even some of our current surrogates who are maybe considering something and they didn't know. I love this. I love that you also help intended parents, and I can't wait for this series to get even bigger, and we bring Crystal into the fold, and we really just talk all things to support the journey in a comprehensive way, as the title says. So I appreciate your time. I know it's late where you are, but I'm thrilled that you took a little extra moments with me. And I cannot wait for the next one, which we're going to skip July and we're going to bring you back in August. So we'll be ready with that. Maybe we'll do 2 in August, but feel free to submit your questions in advance, and Heather will plan accordingly. So thank you again, Heather.
Yeah, absolutely. It was such a joy. Thanks, Cara.